thank you, everybody. Thank you for being here. I know this is the last session of the day, so thank you for sticking around. My name is Alejandra Ullauri. I'm a bilingual audiologist based in Chicago, and I'm super happy to be here and moderate today's panel on cultural and linguistic clinical considerations for our patients for whom English is not their preferred language. We have three outstanding audiologists who have extensive experience providing care to multilingual and multicultural populations. So I'm going to do a little bit of an introduction. How can I? Next slide, please. Oh, there we go. Dr. Crisanda Sanchez is an assistant professor and the interim director of the Children's Hearing Program at the University of Miami Ear Institute. She's a bilingual pediatric audiologist who is a first-generation American-born to Cuban immigrants. She works with implants, hearing aids, and pediatric diagnostics, and over 80% of her patients are Hispanic Latino families who are Spanish speakers. Her most recent publication discusses pediatric audiology measures for Spanish-speaking patients, current practices, and a state of knowledge. We also have Dr. Sprouse, and she's the director of audiology and a pediatric audiologist at the University of Chicago Medicine. Dr. Sprouse is also certified by the American Board of Audiology, and she holds a pediatric audiology specialty certification. She's currently on the board of directors of the American Cochlear Implant Alliance. Dr. Sprouse serves a multicultural and multilingual population in the Chicago area and has presented extensively in this topic. Dr. Claire Umera is a bilingual audiologist at Stanford Medicine Children's Health. She provides diagnostic and hearing aid and cochlear implant services in both Spanish and English, and her patient caseload comes from a diverse cultural, linguistic, and educational backgrounds, including immigrant tech workers and migrant seasonal farm workers. She's passionate about learning the Spanish language and the cultures of the people who speak the language. So with that, we are going to start our panel discussion. And if I can get this. So for many of us that provide services to multilingual and multicultural populations, many times we have to use interpreters. And many of you, I'm sure, have been in a situation where you have concerns about the quality of interpretation. The literature shows that interpretation is not always perfect, even when you use professional interpreters. We know that in this study alone, the 30% of inaccuracies happen during interpretation during the clinical encounter. Those errors are more common when we are using interpreters who are not professionals, so that would be a family member or untrained bilingual staff. And they do happen when we are working with professional interpreters, even when we're working with professional interpreters. So my first question is for Dr. Sprouse and Dr. Umera. Tell us a little bit more about working with interpreters and how you navigate those situations. Give us some tips on how to navigate situations when we have concerns about the quality of interpretation.
I can definitely speak to this. Until really recently, does this sound okay? Okay. Until recently, we were mostly using phone interpreters, and then we got some video-based interpreting services too. So that's really changed things, and I'm really happy to see that this is reflected in these numbers. That is almost as good as, or it's as good as in-person interpretation. I would say maybe one of the best things that I've learned from my colleagues and from our few in-person interpreters who have given me some tips is to, when you first call the interpreter, to give them some background information, especially if you work with children, because sometimes the language or languages that they're learning are not the same as their parents. If you're calling a sign language interpreter and the child is not necessarily signing, they're visual or total communication or C-sign, it will help the interpreter prepare for that type of language. And I also, when I have to call a video interpreter, I usually encourage them to provide me feedback if they're not clear on what's being said, so that a lot of times that the parents are not familiar with sign language themselves, which is a pretty common thing in our area. They may not be aware that their child is having these language difficulties. One of the reasons why we have this really often, this need for Spanish, sign language, English interpretation in our hospital is because we live very close to a farming community. We live near Monterey County, which if you look at all your berry labels and your greens, when you go to the grocery store, you're going to see a lot of Salinas, Monterey, California. So a lot of those people who come to our hospital are farm workers who maybe speak Spanish, maybe speak an indigenous language from Central America, like Mixteco Bajo. And so their children will learn English, Spanish, Mixteco, and maybe some sign if that is the school program that they're at.
And then kind of piggybacking on that, great suggestion, the same thing. Definitely having some kind of one-on-one time with the interpreter prior to the visit starting. So not only to give them kind of some backstory, but just even laying out how the appointment is going to go. If there's going to be some times that you're going to be doing testing where maybe they won't be interpreting, so that you can kind of have those pre-conversations of what the flow is going to be. We have only a handful of Spanish language interpreters that are employed by our hospital, as well as some Arabic, Polish, things like that. And so we do use a lot of video interpreting. And so also in those cases, you know, if things are not going well, to kind of end that call and start again. And making sure that you also empower your patients and families to advocate for that as well, that if this is not going well, that you don't have to continue on with that interpreter and then trying again with another one, because the last thing you want to do is you've got a patient family there, you're in this vulnerable situation, and then with the language barrier, that it's not a positive experience as well. And I think the other important thing is just if there's any learning from the interpreters as well. So if there's other, whether it's medical terminology, just other things, again, just getting feedback about how that appointment went, I think that it goes a long way for all of our patients and families.
I wanted to add one more thing. We love the teach back method, so if you are not confident that the interpreter has hit the points that you wanted to hit, you can ask the patient, can you tell me a little about what you learned, or what will our homework be until our next appointment? And if they seem clueless, it may be not them. It may be that the interpretation didn't go well, or maybe the connection was poor. And if the interpreter or the patient is not very forthcoming about it, that would be your opportunity to go, maybe I need to hang up and get a new interpreter, or maybe I need to make sure I have the right accent or dialect for my patients.
Yeah, absolutely. So the same things that you're doing with your patients where you're not using an interpreter, and making sure that you're getting that back and forth and checking in to make sure that they're really understanding what's being said.
Thank you so much. Thank you for sharing that. We also know that the literature shows that there is significant benefit when the healthcare provider and the patient share the same language. So we know that in those situations, patients are more likely to ask questions. That leads to a better understanding of their condition, and of course, that leads to more adherence to their recommendations. So the next question is for Dr. Sanchez. Dr. Sanchez, could you please share a little bit more about what your team is doing to bring more clinicians that speak the same language as the patients that you serve?
We're trying very hard. As you know, the statistics show, there isn't a high prevalence of audiologists who are bilingual, specifically Spanish-English, as that's the most prevalent that would be necessary in Miami. But I mean, I was just talking to my colleague. We've had this posting that's been circulating for approximately 3 years to find a bilingual audiologist that specializes in pediatrics. I happily coin myself a unicorn, and there are a few unicorns that do exist, but they're few and far between. And I may sound selfish because at my previous presentation, I actually I mentioned our entire hearing implant team, and the majority, about 30 of 49 of us, are from minority populations. Not all of them are Spanish speaking, so we do have a very diverse team. It's probably uniquely diverse compared to what's out in the nation, but even then, it feels like it's not enough. And I know that sounds like, well, you're just being selfish at this point, but It's an imperative need because beyond just the language, what happens is if you're using an interpreter, you obviously have overcome the language barrier, but it's far beyond that. It's patients not feeling, when you ask if an interpreter is needed, oftentimes our families will say, oh no, I'm okay in English. They almost feel like you're burdening them by introducing a secondary person to translate what's happening. They prefer to sometimes use families, but we know that that's not the best mechanism. And so sharing a communication line, sharing culture, having an understanding is such an imperative part of the care line. And the other side of the initiatives to increase our Spanish-speaking audiologists is really also understanding that the cultural nature of moving to a place like Miami. So it's two factors: finding people who can actually communicate in the same language that your patients speak, and moving to Miami and what that means. And oftentimes, Miami is a fun, beautiful place. It's rich with culture, but it could be hard to live here, for especially someone who's never experienced Miami. It's very different. And what we don't want is the cultural shock of just working in a place where not everybody speaks English. In fact, we often talk amongst our colleagues, where we talk about, our Caucasian English, monolingual English-speaking providers. I'm like, how does it feel to be the minority in this room? And where in the United States does that actually happen, where the minority is the monolingual Caucasian audiologist? And it is true in our clinic, but we still need to do better, and more initiatives need to be made in order to push, and it may start at just encouraging Hispanic and Latino population to get higher education. I mean, I come from a family where I'm the only person who ever went to college, let alone getting a doctorate, and that's very standard for my family. Nobody, they graduated high school and they said, I'm good. And that's very common with all of my families, my cousins. Nobody went to college, and so encouraging that from just a fundamental level is where it has to start in order to get, this culture to be kind of more proportionate to the patients that we're serving.
Thank you so much for sharing that. Our next question is, when it comes to providing care to multicultural populations, we cannot take cultural competence lightly. We need to ensure that our teams can navigate cultural differences respectfully so they can provide effective and safe clinical care. So my next question is for Dr. Umeda. Could you tell us a little bit more about what your organization is doing in regards of cultural competence and training?
Absolutely. We, as an organization, Stanford Children's, we have something called the Diversity, Equity, Inclusion, and Justice Committee. And so they have a number of initiatives and sort of subcommittees that send out emails that have different topics that they want the community to be aware of, the providers, the internal community. And so that's sort of a passive way that they disseminate that information. They also, like I mentioned, have initiatives. So one of their new ones is that they have health, equity, I don't know the acronym, but it's HEAL, and the idea is that they've created a series of anti-racism seminars, and I have signed on to be a facilitator for that. So the idea with that is to train our staff members, nurses, front desk, MAs, everyone, physicians, to hopefully be able to identify those types of racism and improve our circumstances internally. And so there's sort of two parts to those seminars. There will be a first part that focuses on structural racism, and the second part will focus on medical racism. And then another thing that we've done in our department is my coworker, Logan Faust, she's an audiologist as well. She decided just to initiate a book club, which was a very novel idea for us. We had never done it. She had facilitated other discussions about race before, and she thought it would be a nice, safe sort of way for us to open up this discussion. I think there was a level of taboo to discuss these things, and so by creating the book club, we had a framework. We had the book that we read was called Cast, The Origins of Our Discontents, which you may have heard of. It's a very excellent book. And so what we did was we had 5 different sessions where we reviewed different chapters of the book. And to give you a brief idea of the book's theme, it's that caste system we typically think of as something that we see in India, where people are in a very fixed caste system and you can't move up very well through it. And the book suggests that in America we have a similar system. Her point was mainly focusing on the experience of African American, Black Americans, who are often locked into those lower levels of society, and how other races can sometimes end up in there too. So we were able to take those concepts and apply it to us as audiologists and participants in healthcare. And so after the book club, we found that we've been a little more open to talking about these things. I know I come from California, so we're very crunchy granola, we're very, I don't want to get political, but you understand what California typically is. And so I know it feels like, oh, well, you were just preaching to the choir by having this book club. But really, when it comes to these cultural things, there is no, let's talk about Hispanic Latinos. Okay, today we're going to talk about Asians. You have to talk about the model and then examine case by case and in your situation how you're going to improve things. And I do think it's been effective for our team.
Thank you so much for sharing all those ideas. I have another question for Dr. Sprouse and Dr. Sanchez. Could you tell us a little bit more how you're incorporating the patients and the family's culture into your rehabilitation program or the rehabilitation plan of the patient?
So that's incredibly important to take into consideration, as it will impact all of your care, your recommendations, guidelines, things like that. And so whatever appointment it is, especially in the beginning, it's really important to take time to gain insight on the patient's culture, their traditions, their values, especially if we think about our birth to 3 population, where we know so much of that language is fostered through daily activities and routines. So it's really important to understand their culture and their traditions, to understand what their daily routines are. As you talk about, treatment adherence, keeping their devices on, or things like that. And so having an understanding of what their day-to-day looks like, it's going to be different patient to patient, especially different based off of their culture. And so it's definitely something that we incorporate. And so spending time in your appointments to get that information, having the patient share, doing observations as you're with the families, looking at their interactions. Is it between parents, caregivers? For some cultures, there may be other people that need to be either present, that maybe they can't be at the appointment, but they're very much important to the decision making. And so you need to have that understanding as well, because again, that's going to impact those recommendations and guidelines. And so all of that is just really imperative in order to have the patient be successful and really to provide that whole child, patient, family, caregiver support.
I mean, I would echo those comments completely. At the University of Miami, we have this angelic little bubble called the Children's Hearing Program, and we're really fortunate to have, it's far beyond just myself as an audiologist, because I think we're part of the initial diagnosis, but we're not a part of, the rest of their trajectory. And it's really a part of including every aspect of this child's development as it relates to the diagnosis and their intervention plan, in order to really meet them where they're at, to address any barriers, and then to hopefully facilitate what they need to be successful with whatever device they end up being in. And with our program, we have psychologists who are Latina, we have a social worker who's Latina, we have an educator who is married to a Latino, but she speaks Spanish. We have 2 auditory verbal therapists who are trilingual and bilingual, and it's such a fundamental part of our team to make sure that we include these members of our team as part of the whole journey of the child, and not just it's the diagnosis, you have to go see a surgeon, and then you're going to hear better. And incorporating the cultural understanding of these families is probably where, when I read the literature and I see papers that saying, well, if a patient speaks a different language than the provider, their outcomes are going to be worse. And I think that there's just a lot of nuances to that. I don't think it's just language. It's about not understanding where these people are coming from, and not understanding, maybe the cultural stigmas associated with hearing loss and why they can't wear it, because maybe mom is bringing to the appointment, but dad is making the decisions and dad is in denial. And that's a very common theme in the Hispanic population with the machismo personalities. The other aspects are, you didn't bring your device today, and, I don't bother asking, things like that come up in conversation of, oh, well, they're staying in a motel because they're homeless. And so understanding the influences of what the health disparities that affect this population and incorporating that in the support line that you can provide to these families is the difference between a child who will be successful and a child who maybe will have barriers on every aspect of their development. Within our team and inspired, I don't know if the pandemic inspired anything, but it did inspire an opportunity to open a study with our program where we did a multidisciplinary team specifically for children undergoing the cochlear implant process, because we understood that there were a lot of appointments that we needed our patients to go through, and that was beneficial. Some people will say, well, that's another barrier, right? You're making them come a million times. But the reason is because we require all of our kids to see our psychologists so that they understand the psychosocial impact of needing a cochlear implant, not just the fact that the device goes on their head and they start hearing. And the pandemic inspired us in a more of a craniofacial model where the family would have an opportunity to meet with all specialists in one Zoom meeting. So the parents arrived and anybody could show up because you can just send them the link. So we had abuelos, nannies, tias, primos, everyone who was involved in this child's care was on the Zoom call, and on that Zoom call was their audiologist, their speech therapist, our psychologist, and our educator. And we talked about every aspect of what this implant is going to mean as it relates to school, as it relates to life, as it relates to hearing, and as it relates to speech development. And anecdotally, I talk to my colleagues all the time, I'm like, do you see that it makes a difference? And night and day, our families understand, they know what they need to do, and it's just they have a sense of safety when they're like, wow, everybody's on the same page and everybody shares my culture. They understand why we may be resistant to this. They understand maybe that their faith may impact their ability to make decisions, but we're here to support them and here to help them guide those really difficult decisions that they're making for their children. And so different creative ways are mechanisms that we use on our program to really meet our patients where they're at and not expect them to be where we, the gold standard. It's just not realistic for the population that we're serving.
Thank you so much. That's a great tip. Thank you for sharing your experience working with these families. I have a question for everybody. If you can raise your hand, how many of you are working with patient navigators in your teams? Okay, some of you, thank you. So the CDC describes a patient navigator as someone who helps people get the healthcare and other resources they need to be as healthy as possible. Patient navigators work with people, their families, and their caregivers to overcome barriers, such as lack of transportation, lack of childcare, speaking another language other than English, and of course the mistrust of the healthcare system that may exist. So my question to all our panelists are, based on your experience, do you think that patient navigators could play a crucial role in decreasing healthcare disparities in ear and hearing care? Who wants to go first?
Should we all say yes together?
Yeah.
Yes.
Absolutely. I mean, without a doubt, it's actually the next position that we want to open, but it's challenging. We talked about this of like who's funding it and justifying a position that's really non-billable. You don't reimburse a service line, but understanding the non-billable benefits of helping families navigate these very complex situations. Uniquely in Miami, in order for a child to get a cochlear implant, they have to go to another institution to get their imaging. And that institution doesn't share the same EMR system, and we have to hope that the patient brings their CD at their appointment. It's a system designed to fail, and our social worker currently serves in that role, plus one of our coordinators who is actually speaking at a panel on Saturday. She's here, Maria. She is an angel, but she is the light for these families, and she's a point of contact for families that they know that no matter what, she'll pick up the phone and help them. And ideally, in a role, a patient navigator will navigate any aspect of their care, not just as it relates to the cochlear implant process or obtaining your authorization for your hearing aids. So there's definitely a space, at least specifically with pediatrics, on helping navigate our patients through this system that unfortunately is almost designed to fail them, and they're already at a disadvantage from being part of health disparities already. So, yes.
I echo all of that, so absolutely. I think just being able to have a point person, even, we're fortunate enough that we're all housed in the same place at our main campus, but still being able to have a point person obviously makes it much easier for families to navigate. And certainly if there's language barriers, culture barriers, things like that, again, just being able to have a point person. I think that other ways that it can help is just facilitating, again, just along that entire process and not just in the hearing healthcare. I'm glad that you brought up the point about even like vaccinations and other medical things. And so when we think of particularly like African Americans, there's a lot of distrust in the medical facility. And so being able to have a patient navigator that can also help that family navigate the process, connecting with social work. We have a social worker that's dedicated to our team. We have a clinical program manager to also help navigate our patients through this process. But being able to have that person that can help answer those additional questions, have that interprofessional collaboration among all of us so that we can all be on the same page with the patient, because there may be things that I get out of the appointment that another provider will get out of their appointment, and being able to have that information sharing. And so having a patient navigator can also help with just kind of not only that whole patient, but even with the team as well.
We don't have a formal patient navigator, and I know that since a lot of us didn't raise our hands, maybe we weren't as familiar with that role. I do work in a large hospital, but our clinic is not housed in the main hospital, so we don't have direct access to social workers, psychologists. We don't really even get to meet them a lot of times, so it can be a big challenge to find someone to serve that role as a patient navigator. So our solution, until we do get that social worker position approved, is to all fill that role together. Someone that I wanted to highlight is the two in-person interpreters we get are both sign language interpreters, and like I mentioned, we have a lot of Spanish speakers, and one of them is trilingual Spanish sign English proficient, and so her office space is right next to the social worker office. So we can page social work and ask for help, but really a lot of the resources come from asking each other, how should I help this patient? Asking this one interpreter, Neva, how can we help this patient? What do you know? And sometimes she'll relay that message. But also asking people like, if you have a local school that is deaf and hard of hearing serving, or if you have the manufacturers, they help a lot with some of these things too.
And then I think the other point that I would make is just spend time talking to the patient and asking what their barriers are, because the barriers that we think that they have may not be the ones that they report. And so, and in order to make, again, the best recommendations, provide them with the most support, the most accurate support for what they need, it's really important to spend time finding out what they actually identify as their barrier.
Thank you so much to all of you. Thank you for sharing your expertise and your experience in this important topic. I don't know if we have any questions in the audience for our panel. Well, thank you everybody for making it to the very end. We have one question.
Such a great panel, and Alejandra, I think we can't let people go without knowing what you're doing to try to change the landscape for access to Spanish-speaking patients in the U.S., and you're doing really great things as a solo provider. What I would like to know is, how can these bigger organizations like ACIA, AAA, AAO, how can they make a difference? How can they get involved in a bigger level than just saying they have a committee on diversity and inclusion?
Thank you so much for your question. Thank you, Meredith. AAA, the American Academy of Audiology, is working with the NIH to get some funding to help students that come from minority backgrounds to get into the pipeline to become audiologists. So that was to address something that Dr. Sanchez was saying. We need more diversity in the audiology program, so then we have more audiologists from diverse backgrounds, from diverse linguistic backgrounds to hire. Something that I've been working on is just to bring medical Spanish for audiologists. Dr. Umera is a great example. She is bilingual, speaks Spanish and English, and she's non-Hispanic. And so we have an untapped resource of bilingual audiology students, and we just need to make sure that they have the Spanish language skills at a level that they can provide safe and effective care in a clinical setting. So we're trying to teach them. So we are offering courses that teach medical Spanish, but of course the course doesn't teach them Spanish. They have to have an advanced level of Spanish so we can teach them the clinical side, again, to ensure that there is safety and effectiveness when they provide care. Thank you, everybody, for your interest, and thank you for being here today.